I feel like you get really lucky if the kinds of cases you get often have LCDs, because it's some kind of formalized guidance in a industry that lacks guidance in general. Hi everyone, this is Mariam Treystman from the Home Health Consultant, and today we're going to talk about LCDs, or better known as local coverage determinations. But first, if you like our content, please subscribe and share. First, what is an LCD? Why are they important? And when do we use them? So LCDs are, as we said before, local coverage determinations. These are topics from your MAC, Medicare Administrative Contractor, that explain how Medicare interprets certain regulations from a clinical setting in response to chart reviews. Because there isn't really much out there in the world about how to chart in hyper-specific clinical cases, because patients generally have such individualized care, right? Every patient has hypertension if you're in the geriatric community, but the combination of diagnoses and the various kind of ways they can be uniquely expressed, it creates a situation where it's hard to have any kind of templated real documentation or care that Medicare can present as do this way. And of course, that also is based on clinical experience and expertise. Clinicians are, of course, supposed to know how to handle these various cases based on their background, education, and experience, and so on. But even though we do, of course, trust our clinicians with their knowledge and experience and understanding of how to treat patients, especially those that are very experienced, Medicare still has standards for payment. And so LCDs are their interpretation of those standards depending on the case. Now, this really comes in handy when you are working with ADRs. What is an ADR? An ADR is an additional documentation request. This can happen pretty much as a prepayment review or a post-payment review, meaning you could build the claim and then an ADR is requested so that pretty much someone from the MAC or a third-party contractor reads the case to determine if they're going to pay you. It can also happen where you've billed the case, you got paid, and now you get a list of charts or one specific chart that the MAC would like to see if you are kind of doing things the correct way. So when there are ADRs in question, it's hard to understand sometimes how to chart, because a lot of agencies feel like they're doing everything right. They're, justifying medical necessity. They're justifying their homebound status or their terminal illness. Their CTI certification of terminal illness is everything's done properly, whatever. The agency may feel like they're doing everything right, and they may be surveyed on these charts, and these charts might be flawless in survey. And they might submit them for ADR and get a rejection from the ADR. And so this leaves a lot of agencies very confused about this process. The reason that you might have a zero deficiency chart fail at ADR is because there are different requirements for survey and for payment. There are Medicare participation requirements that are mostly procedural, and then there are billing requirements that are a little more in depth in terms of qualification of the patient and care delivery. So we're really talking about two different things. And the mistake that a lot of agencies make, which I truly believe in my experience is not their fault at all, is that agencies often feel that the survey process and the enrollment process captures all of the requirements in general, but that's not true. It's easy to make that mistake, and honestly, at the beginning of my career in healthcare, I also thought that it really like shocked me that you can have a perfect chart procedurally and get a rejection on that chart through an ADR. Now, full disclosure, I'm not a clinician. I don't have clinical background, but I've been in this world enough to like be able to like read a chart and find issues or, whatever. Like I can more or less read a chart. Can I go treat a patient? No. Can I probably catch every issue in a very highly complex case? Also no. But like the basics of charting, things like that, I understand. And so this took me a minute as well to understand that there's procedural guidance, regulations, and vulnerabilities, and also kind of like billing related procedures, guidance, vulnerabilities, and things like that. Where this gets tricky for people, I think, is the way the Medicare system is set up, which I understand why they do it like this. It's set up in a way where you bill, and when you bill, you're like not really sending any information. You're sending a visit list pretty much, and like a diagnosis list, and like who's the doctor. I mean, that's like the more or less what you're sending, right? And so when you're billing, you just send it. It's pretty much an invoice, and then you get paid through an automated system. And so like you could go a year or 2 years like this, never knowing that you might be charting in some kind of like wrong way for billing. And so the requirements for billing are checked through this ADR process. The ADR process is different depending on who the ADR comes from, and the ADR can come from a variety of like third-party contractors or your MAC or whatever, and for a variety of reasons. One reason that you can get an ADR is random selection, like it's your unlucky day. Another reason that you can get an ADR is that the billing and maybe data transmission like iKeys or HARP, whatever, like Oasis transmission or HARP or HIS transmission, not HARP, sorry, or the HIS transmission, like the combination of the claim and the Oasis data or the HIS data could create some kind of like pattern that their algorithm is looking for. And these algorithms change like all the time. Anyone who tells you that they know what the algorithm is looking for or like why this got selected, like through these like algorithmic kind of like selection processes, is lying to you. No one knows unless they are like besties with this people in Washington in CMS. No one knows. And it's supposed to be like that because these things are looking for trends that could indicate, for example, fraud and abuse. Trends that could indicate improper acceptance of patients that do not qualify for service. We don't know what they're looking for. They might just be looking for anybody with this specific like wound supply. Of course, it's more complex than that, but these algorithms change constantly. And also, I think this is just speculation because nobody knows. If you trip up the algorithm, like you get caught up in that and get ADRs, I think at that point, you get ADR'd probably on the claims that may have fallen into that search, but also some other random claims surrounding it. Because I've never seen anybody get like 10 charts ADR'd and they're all wound care charts, or like they have some common, principle. Typically, it's just seemingly random. So And this happens actually in California. If you get a complaint survey, the surveyors will come in and they'll ask for the chart that's related to the complaint, but then they'll ask for like random charts around it too. So you never really know exactly what this is about unless they tell you. Like, yeah, they might look at like, let's say 10 charts, 5 charts that whatever don't have a common theme, or they don't. But unless they tell you exactly which one it is, or you find out through like that person has already complained to you or something, you're not going to know. It's the same thing with the ADR algorithms. Like, I've never really seen people who are just getting these ADRs that are like, I know it's because of this. Like, it kind of always feels random charts, random whatever. But depending on who is ADRing you, the purpose for the ADR changes. We have like a more in-depth article about this, so you can go and read about like who the ADR comes from, what it means, like based on who's ADRing you. We're not going to get too much into that here. The purpose of this topic today is to explain how to better prepare yourself to respond to ADRs. And it's less about like once you've gotten the ADR and more about how to chart in a way that protects you. And the real, like, the truth of healthcare and charting in general is that you're not charting out of thin air. That means you have to treat in a way that protects you. That means you have to select your patients in a way that protects you. That means sometimes you can't take a referral because they don't qualify. So appropriate charting and appropriate treatment starts with, just like in compliance, right? Like understanding what it is people expect of you. And this is the same in all aspects of life. Like you can't really perform to standards that you're unaware of. And so to find the standards and understand what's expected of you, this is where LCDs come in. LCDs are what has been decided by Medicare as the appropriate way to treat and document specific conditions, diseases, instances, and issues. It's not one thing. Like it could be like, for this very specific diagnosis, treatment, this is what we need. Or if you have therapy, this is what we need, or whatever, things like that. So it's not like, it just kind of talks about everything. The way that LCDs are decided is by committee. So what happens is through this process of ADRs, Medicare, like CMS also just has tons of data, right? Like they're always ADRing someone. Anybody in the business long enough is going to get ADRs. You're going to have to go through this as a company. Some of them are just like probe and educate. So like they'll reject the thing, and then the point is to educate you on how to do it better. As long as it's not like they're looking for fraud and then they find it, or abuse or waste and then they find it, typically you're going to be fine. Like even if it's not great, as long as you're not like killing patients or just like grossly, admitting people that are not qualified or whatever, you're going to, get a little slap on the wrist. You'll get some education. They might like ask for money back, but it's not a problem that you can't get past. And so what happens is, as these like probably thousands of ADRs a month are coming in through these various third-party contractors or MACs or whatever, CMS is building their database. As they get probably enough through this algorithmic approach, right? Like maybe the algorithm looks for negative wound pressure therapy. So when they get like 100 cases, or like probably more like 1,000 cases like this, now they get some kind of like committee to come together and decide what exactly is it that we're looking for. I'm not saying that that's the exact process. Like it's not like the algorithm targets something, they build data, and then they respond to it. I think just anytime they get like a lot of data on one specific thing, especially probably if like that specific thing isn't being followed appropriately, like they're just getting a lot of rejections in this one area. Now we have a committee reviewing it to give LCDs. The way LCDs work is that every intermediary or MAC has their own LCDs. It's not CMS has LCDs. It's that like NGS has their own list of LCDs, Palmetto has their own list of LCDs, and so on. That's why they're called local coverage determinations. It's the coverage determinations of that local area, which is like maybe half the country, but like the point is of that region. And so what they'll do is they'll give this committee comes up with like just an extensive informational process about this topic. So how do you use LCDs? Well, this is where you want to have very involved clinical leadership. The day-to-day job of the DPCS is the overall clinical management of the agency, of all the clinical departments of the agency and so on, right? But I mean, like most RNs can do this job. Where you want to have, once your processes are set up and things are flowing, you want this DPCS to just start researching LCDs for the kind of like just general treatments you're doing a lot. In every agency, you're going to have a variety of cases that come in. It's going to be a variety of diagnosis and so on. But at some point, especially if you start niching, even if you don't, you're just going to notice like, I'm getting a lot of like, I don't know, whatever, this IV antibiotic cases. I'm getting a lot of like really, really extreme wound cases. Like you're just going to start to get a lot of certain types of cases based on 1,000 things. Like what kind of clinicians do you have? What kind of referrers are you referring to? Are they specialists? Are you niching? Whatever. Your clinical head of staff needs to go and spend like 1 day a month. I mean, that's my recommendation. And I'm just making this up. This isn't like formalized advice. But like they need to go and really spend time researching these LCDs on their MAC and other MAC websites to make sure that you're providing the proper treatment and you're providing and you're conducting like the proper documentation reviews and that you're documenting appropriately to that case. Not every situation has an LCD. So like, I feel like you get really lucky if the kinds of cases you get often have LCDs because it's some kind of formalized guidance in a industry that lacks guidance in general. There's a million things out there about what's the rule. There's nothing out there about how do you implement the rule? What is the intention of the rule? Like everything just kind of regurgitates the rule. Well, okay, great. So LCDs are formalized clinical guidance, which is severely lacking all over the place in this industry. First and foremost, the biggest like LCDs you really need to start, like if you're just new to this, you've never heard of it before, like it's just not practiced in your company, start with eligibility requirements. There's definitely LCDs in your MAC and other MACs about eligibility requirements. Because if you might be treating the most complex case in the world, like 5 wounds, IV, I don't know what, like ulcer, this, that, you know, bed bound, blah, blah, blah. Recovering from 15 surgeries, I don't know what. If you don't get your eligibility criteria down, both in selection, treatment, and documentation, that chart's not getting paid if it's ADR'd. That sucks. It really does suck. It sucks because when a chart is ADR'd and rejected, you have to pay that money back. They don't say, pay me the portion that was profit. You pay it all back. You're not getting that money from the clinicians that you paid them for their work that they charted on. You're not getting the money that you spent on medical supplies, the time your office staff spent, right? Like, no one's going to refund you. And so as like the head of the agency clinically, the administrator, or like the owner, you need to make sure that you have at least the eligibility criteria like down and perfected. Because like, okay, in home health, in hospice, it's like slightly more clear, right? Like it's like a little more concrete. And you have backup documentation from like doctors and things like that. It's a little different. In home health, the eligibility criteria is just like so vague. Homebound status, medical necessity, like, yeah, they give some guidance as to like what that means. But so many people end up getting their ADRs rejected just for these simple principles. Like, okay, you can document, homebound status. Okay, they can't leave home unassisted. They can't walk more than X many feet without like assistance from another person. I don't know what, right? Like, or like dementia. I don't know. The LCDs, where the guidance in the conditions will give you like 2 paragraphs on this. The LCDs is like this. So this is your screen. And this is the LCD it starts, and then you're scrolling, like this. It never ends. It's probably like 30 pages of guidance. And they go into specifics. In this case like this, in that case like that. And so it's worth checking out, Same thing with medical necessity. How vague is that? I've seen like charts that, I mean, this is a bedbound patient, what's more homebound than that? Or like truly, like there's no caregivers around, whatever, and it gets rejected. Like learn the LCDs for eligibility, because like without that, it doesn't matter if you're providing like hospital level care on a day-to-day basis to these patients. If you don't get your criteria down, that's it. And one of the things, I mean, this isn't a talk about, we can do a separate video on this, but this isn't a talk about how to justify eligibility. But like that eligibility criteria doesn't only need to be there on day one. It needs to be there on the day before the last day as well. Like that person needs to be eligible every day of your care until discharge. And so when that eligibility criteria changes, right, like they're kind of especially in home health, where the goal is to rehabilitate them to an independent status or as close as you can get. As this changes, you need to constantly justify this homebound status and medical necessity in every note, not just at research, not like everywhere. So really get familiar with LCDs around care you're constantly providing, around situations you're constantly providing. It is the difference of getting like $1 million to have pay back or not. Like it literally is going to make or break the financial health and the longevity of your business. Like I can't overstate this enough. And what's really sad to me and also unfortunate is that so many companies are just unaware, like full-blown oblivious to this. I don't know why, for like 100,000 different reasons, and it's well-meaning companies, and they think they're doing the best that they could do, right? But they're just like not that aware of this stuff. So again, really, really try to get these LCDs down for eligibility criteria and things, and just like common processes in your company, because your company like really depends on it. And that's that. So that was my little fear-mongering talk about LCDs, local coverage determinations. And thank you so much for listening to me vent about this. And I'm Mariam Treystman from the Home Health Consultant. And of course, if you like our content, please like, share, subscribe. Thank you.